days. Roshna is here, Shaista, Nazia. Is this Nazia Patel? Hi Nazia. Assalamu alaikum. We will wait for a short while and then inshallah we'll start the webinar. Dr. Sara is here as well. Sara Sakhtar. Thank you for joining us. Okay, good to see you, Nazia, and good to see Roshna as well. So I'll be needing some volunteers as well today for the two topics that we'll be covering. So I welcome you all from MedExam Expert. Previously also I have conducted a webinar on maternal medicine and one was on core surgical skills for laparoscopy. Thank you all of you for joining us for this session. So in today's session, we wanted to cover some of the important exam topics, one of which is postpartum contraception, because it has repeatedly come in the exam, and the other or other new topic is thrombocytopenia in pregnancy. So basically what I wanted is to cover two of the TOG articles. The TOG article of thrombocytopenia in pregnancy is rather an old one, but still it has been an exam topic, so we thought to discuss this new topic for the exam. And the other topic is postpartum contraception, which has also come repeatedly in the exam. So I would like all of you to participate, and I will be needing two volunteers. So who would like to participate and present the first station? Yeah, sure, Nadia, you can go ahead. So Nadia, I'll give you 2 minutes reading time, and then I'll give you 10 minutes for presenting, right?
Okay, ma'am.
Yeah. So your reading time starts now. If you have read the instruction, Nazia, let me know and we will start this session, the presentation.
Okay, ma'am, I have read.
Okay, all right. So your presentation's time starts now.
Okay, ma'am. Hello, I'm Dr. Patel, one of the doctors in the postnatal clinic today. Can I confirm your name and age, please?
My name is Stephanie Morris and I'm 34 years old.
Okay, from your case note, I have read that you are here for postpartum contraception.
Yeah,
Is it
that's
right?
right. Yeah, that's
Okay,
right.
good. Can you tell me more about your concern regarding this meeting?
Yeah, so doctor, one of my friends, she told me that I can get pregnant 21 days after the birth of the baby. So I was very concerned. I went to my GP, and the GP thought that because of my medical condition of the previously I had breast cancer, my GP thought that it would be better for me to consult you here in the clinic and to be seen in the specialist clinic.
Okay, good to see that you are very much concerned, and I would be answering all your concern but before that, I would like to ask you a few questions, if it's all right with you.
Yeah, that's fine.
Okay, so how are you feeling after delivery?
Yeah, things has been good.
Okay, how's your baby?
Baby John is very good,
Okay, good.
keeping well.
Good. Are you feeding him?
Yeah, I'm breastfeeding.
Okay, good. So things are going fine. And this was your first baby?
Yeah, John was my first baby.
Okay, how was it delivered? It was delivered normally, or you had a cesarean section?
Baby was having some problem with there was problem with the fetal heart trace, and they did some vacuum extraction at the time of delivery. But I was
Okay,
fine otherwise, and John was also okay.
okay. So you were discharged at a normal time.
I was discharged after 2 days, yes.
Okay, any kind of fever or bleeding after that?
I didn't run any fevers, and bleeding was just I think the normal one. There was no
Okay,
excessive bleeding or any clots.
okay, good. So how were your periods before your pregnancy?
Period has been fine always, very regular.
Okay, okay, good. For how many years back you had this breast cancer?
So I was diagnosed almost 4 years ago,
Okay,
and then the breast doctors, they diagnosed it, and then I underwent a lumpectomy, and after that
okay,
I did receive some radiations as well.
okay. For how many months you got this medication?
So there were few sessions of radiotherapy, and the treatment was
Okay,
stopped after a few weeks. But I've been very
good.
regular with my doctor. They are happy with my
Okay,
condition.
so you took any kind of medicine for a long period, any oral medicine?
No, I didn't receive any
Okay.
tablets or
Uh,
anything.
okay. When you last visited your doctor, breast doctor?
Um, so I visited once during the pregnancy, and he was quite happy
Okay,
with everything.
okay, okay, okay. So you are following up. Very good. So you had any kind of other surgery, anything before other than this surgery?
I had my appendix
On
removed when I was very young.
okay. Elsewhere, there's nothing. Okay. Any kind of illness for you, like, for which you see your GP regularly? Any sugar, blood
Um,
pressures, anything?
no, apart from this, I don't have any medical illness or anything.
Okay. Any family history of concern regarding any cancers or anything?
Everyone in his family is doing very well. No problems as
Okay,
such.
good. Okay. What do you do for living?
I'm a school teacher.
Okay. How's your support at home?
My partner is very supportive. We are together for almost 6 years now.
Okay, good. So I would be asking a few intrusive questions if it's okay with you.
Yeah, that's okay.
Okay. How's your sex life?
It is okay. I mean, is
Okay.
there anything
So
in particular?
any bleeding or pain or after having sex or anything?
No, I don't have any such problems.
Okay. So have you tried any birth spacing before this period?
Not really. Before I was diagnosed with cancer, we have been using just condoms. And
Okay,
after my treatment was completed of the breast cancer, my doctor advised me not to get pregnant for 2 years. And at
okay,
that time as well, I've been using we've been using condoms.
okay. So what is your height to weight ratio? Do you know that?
It's it's 26.
Okay. So any allergies from your medicine, anything?
I'm allergic to penicillin.
Okay, I will write it down in my notes. Do you smoke or take alcohol?
I drink occasionally, and I don't
Okay,
smoke.
okay. Thank you for sharing this information, Stephen. Do you want to add anything?
Um, yeah, I just want to know about the contraception and what are my
Okay,
options and all that. Yeah.
okay, okay. I will be answering these. First, I would like to examine you in the front of a chaplain so that I can see examine your chest and examine your tummy. Okay, and if it's okay with you.
Yeah, that's fine.
Okay, okay. Now coming to your concerns, as you have said that you had gone to this breast surgery. Okay, so there are few contraception methods that you can follow easily. Okay, so after
Okay.
21 days, if everything is going fine, so there are multiple options. Okay, you can go through if you want a longer period of birth spacing, you can go through for the copper T. It's just like a T-shaped device made up of plastic, and it has a T shape which just opens up inside the womb, and
Mm-hmm.
we can apply it after as you have just uh, as you have just cleared your this period, and you have undergone this postpartum period you have completed. So we can go through this procedure by just inserting inside your womb, and it will open
Mm-hmm.
up and it will be kept there for at least 5 to 10 years. Okay, so
Okay.
first option is your the copper T. Okay,
Okay.
heavy bleeding. It can cause some kind of irregular bleeding for 6 months, so we have to monitor it. If everything goes fine, so it doesn't have any kind of hormone which can produce anything or any side effects. Okay, because you have a history of breast cancer, so we have to be very much careful about it. Okay, so we should opt for those methods which don't harm you in any way. Okay, Stephen, are you with me?
Okay, doctor.
Am I?
One of my friend has a Mirena coil fitted, and she's quite happy with it.
Yes, Marina oil is also good, and it can be kept for 5 years, 5 to 7 years, and they are. It's a good, but the action, the basically, it doesn't. It kills the sperms so that it can't enter inside your womb, and secondly, it inhibits. Basically, it stops the baby's placement. So that's why it's a very good method. It has a very successful rate. Nearly 99 out of 100 female are happy with it, and there is no kind of any complication. Okay,
Okay.
and
So I
in some we keep a thread beside it so that the female can look into it and confirms its presence. If the thread is not felt, then we call the female to us so that she can see we can feel the thread. If thread is not seen, then we have to go for the ultrasound. And there are
okay.
small risk factors of uh, uh, hurting the womb if while keeping it, but it's a very very small risk, like less than 1%.
So
Okay,
I can
Stephen?
have the Mirena coil, right?
Yes, you can.
Okay. Is there any other options, doctor?
Yes, you can have easily. And
Okay.
your other methods is the copper tea that I showed you. That Marina has a hormones inside, and
Mm-hmm.
it basically gives the environment to the uterus, which has
Mm-hmm.
basically progesterone. And the copper T, which I was talking about, is other device which is just having a copper inside, which doesn't have any kind of hormone.
Okay. So,
Okay.
doctor, is there any other options?
Yes, you have multiple options. You have other the injectables option. Okay, you have options of implants. So there are many options, but first of all, with your permission, I would like to have your case note regarding your breast cancer, because I have to see what kind of tissue was there present, if it was positive for any kind of hormones or not. Because according to that, we would be able to suggest you the best method for you.
Okay, so your time is up, Nazia. Is there anything else that you would like to ask?
Okay. I will be booking next appointment with my consultant, and I will be giving you some patient information. Thank you.
Thank you so much, doctor. How was the station, Nazia?
I was very much confused.
That's okay. It's okay to be confused now rather than in exam.
And I forgot to ask this histopathology, basically. The hormonal, that was my mistake.
Yeah, I understand your concern, but we don't go into such details. Okay, so only the breast CA. Breast CA is enough. That is a big, red flag for any hormonal medication. So let's go step by step through the whole presentation. Intro and agenda making was very good. Okay, so then we came to the because you have been presenting in the Telegram group, right? So this is why you have been very fluent with the introduction and agenda making. So that's good. Keep practicing there. And then we came to the history of presenting illness, in which you very beautifully asked about all the delivery questions, postpartum questions. You asked about the mode of delivery, how was the recovery, how is baby doing, if she is breastfeeding or not. We can also ask about any pain or bleeding. All right, so all these questions you did ask. And then you asked about the history of breast CA, which was also good. You asked about the diagnosis, then what was the treatment, and then how has been the follow-up, and any medication that she has been taking. You covered that as well. One of the points that was missing was the use of the contraception, like for how long she wished to have the contraception, what are her preferences for you have to ask about the whole contraceptive history as well. And then when you are taking the contraceptive history, keep your options in your mind, and related to these options, you have to rule out the contraindication in the history. So for example, if you were asking about you wanted the copper IUD to be fitted, here you will ask about and rule out any contraindication, like any history of excessive like postpartum sepsis, PPH. All these questions you have to ask. Any previous history of PID, sexually transmitted infections, right?
Okay.
So keep this point of contraception, right? When you are making your notes, make this point of contraception, because it is important to know in the history. So then we completed the whole template. Yeah. So then you came to the surgical history. Whenever the patient says that she had some sort of surgery, even if it was appendectomy, you have to ask about the recovery, right? So maybe after appendectomy, there can be complications. She may have been complicated. Maybe it was a gangrenous appendix for which she was in the ICU or something. So always make a habit of asking about recovery after surgery.
Okay, how was the recovery?
Yeah. And you did ask about the sexual history after signposting. That was good. You asked about allergies, and you noted it down in the chart. That was a very good patient safety point. So then we came to the examination. In the examination, the most important point was the bimanual examination, right? Because you did ask about abdominal and the blood pressure, BMI. But for the patient where we are thinking to fit a copper coil, we have to do the bimanual examination to assess the suitability for fitting the copper coil. Then we came to the explanation, and you said in the start. Yeah.
Ma'am, should I tell her that I would be doing a digital examination?
An examination from down below should be okay.
Hello?
An examination from down below. You can say an examination from down below. Yeah, that should be enough. The examiner knows that you are talking about bimanual examination, right? So then we came to the explanation. So in the explanation, in the start, you did say that we cannot give any hormonal medication, but then you went away from the track. So applied clinical knowledge has to be very good here. We cannot use any hormonal medication. You can't hear me? Let me ask.
Now your voice is clear. I missed the clinical part.
Okay. You missed which part? Can you hear me now,
after this
Nazia?
down below.
Yeah.
Yes,
So then
ma'am.
we came to the explanation part, right? And then,
Yes.
so the first line in the explanation is that you have to say that there are no hormonal methods available for a breastfeed patient, right? So then you came to the
Yes.
options, in which the first thing that you discussed was a copper T. And I wanted deliberately made you confused about the Mirena coil. And your answer should have been a big no, because that is a hormonal coil,
Hormonal. Yes.
right?
Yes.
And then you will give other options. I'll show you slides of how we are going to make an explanation and the best option. And for each of the option, you will have to give the mechanism of action, then the failure rate, and any pros and cons. And then you will ask the patient about her preferences, and then this is how we are going to close this session. Okay, so I'll just give you the slides.
Dr. Laila, before the slide, I have a question. Salam alaikum.
Walaikum assalam. Who is this?
Anam.
Hi, Anam.
Hi, Dr.
Anam?
Yeah, Anam. Doctor,
How are you, Anam?
shall I ask you a few questions, Doctor, before
Yeah, sure, Anam. You have been in our previous webinar as well. Am I right?
Yeah, with laparoscope. Doctor.
Okay. So what's your question, Anam?
Yeah, I have two questions. First one is, patient is willing for tubal ligation, as this case, another case, complete her family, and she's willing to tubal ligation. So shall we go for a tubal ligation in such scenario?
Yeah, of course, we have the options. So we have got, I'm going to discuss all the options with you, and tubal ligation can be done. But depending on, you have to tell the patient that this is a permanent method, right? This was just her first baby. Maybe she wants more children. So you have to discuss the pros and cons of each method, and then she will select for herself.
Yeah, complete her family, not this case, but the same age, with CA breast. When shall we do tubal ligation? Now she's 3 weeks. Shall we postpone till 6 weeks, or shall we go 3 weeks now? Suppose the uterus is involuted, right, doctor?
So for the, we even do it at the time of cesarean section, right? And for the postpartum patient, most of the times we call them at 4 weeks, when the patient has recovered. And at the 4 weeks time, we are going to call her and we will do the postpartum interval ligation. But meanwhile, she'll have to use some other interim method or some bridging method, right?
Yeah, it's not preferable after 3 weeks, or shall we postpone to 6 weeks? Because we know immediately post-delivery we can, if the patient already signed before, like because large uterus, not big uterus, maybe mini laparotomy. But now it's supposed 3 weeks, the uterus is involuted. Shall we go now for tubal ligation? Or
there is not, like in the copper T or in the intrauterine devices, there is, especially the FSRH guidelines says, particularly says that you cannot do it after 48 hours. You will have to wait for 4 weeks, right?
So you mean for tubal ligation, according to the guideline, it will be 4 weeks.
For tubal, like obviously it is a surgical procedure, and the uterus is involuting. So you can give the patient time to recover from the delivery, and then you can plan any of the surgical procedures that you want.
Okay, and also,
but in the interim time, you have to use some other contraception. You cannot leave the patient as such.
You mean it is 4 to 6 weeks, not before that?
So you are asking?
Yeah, doctor, time of tubal ligation. If now she's came 3 weeks post-delivery, time of...
There is no contraindication for tubal ligation at any time. There is no contraindication.
Yeah. Okay.
Anam.
Yeah, but maybe either mini laparotomy or either laparoscope. Laparoscope when the uterus involuted, or it can be done at any time.
You will give the patient time to recover. Okay, so you can do it at 4 weeks time, but before that you will use some other interim contraception. The patient will guide you about her options. So she is not going to make you confused on this thing, that at what time exactly, at 23rd day or 24th day or at 28th day. So it can be 4 weeks.
Yeah, doctor, I have real life scenario. Like this case, she is para 3 and she's in her 30s, and she has a known case of CA breast, and now she's on medication, and she went for tubal ligations. Is there any possibility to discuss with the patient to go for bilateral salpingo or oophorectomy, because she is breast cancer on tamoxifen? Probably there is a BRCA1. I don't know whether they did or not for her. In such condition, shall we discuss with her, or this is MDT, or it should be?
Look, Anam, don't confuse the postpartum contraception with the risk reducing surgery. Okay, the bilateral salpingo-oophorectomy is a risk-reducing surgery, and a 30 years old lady, that is a big thing. You cannot decide it on your own. So obviously, it will be an MDT. Before that, it will be her breast doctor will be involved. The genetic counselor will be involved, and after that, that is going to be a very serious decision of bilateral salpingo-oophorectomy. Right. So right now we are discussing only the postpartum contraception.
This is real case. That's why it's come to my mind. Okay, thank you, doctor. So it's MDT. This condition. Okay.
Yeah. So do we have any other question? Okay, so we'll proceed as how we are going to cover this station. So Nazia asked about pregnancy and delivery question. When was the delivery? Any pain, bleeding, any breast tenderness, any cough or pain in the legs? So all the postpartum question we will be asking. And very beautifully, you have to ask about the baby. Don't forget the baby when you are talking about the mother. For obviously in breast CA, we are not going to use the hormonal methods, but if there is some other postpartum contraception station, then you have to ask about any pregnancy related conditions like PIH, GTM, obstetric cholestasis. Then Nazia did ask about the breast CA question. When was she diagnosed? What surgery was done? If tamoxifen has been used? And Nazia do ask about her mental condition, like how she has been coping after the surgery, after the breast CA. And the very important is the history of contraception, previous contraception. Make sure that she's in a stable relationship, for how long she wish to use contraception. That will lead you to making a suitable plan for her. Then we will rule out any previous history of PID, any vaginal discharge, lower tummy pain, any fever, previous history of sexually transmitted infections, any heavy bleeding after delivery, or have been running any fever, to rule out postpartum sepsis. And we'll definitely ask about breastfeeding, and especially ask that if she want to exclusively breastfeed for 6 months, because that will give us an option of lactational amenorrhea method. Right. Then we'll ask about obstetric history, medical, surgical, family history, allergies, social habits, BMI, social and mental history. All of which was covered by Nazia. And then in the examination, the bimanual examination is very important, right? And we'll obviously do a BP, BMI, and abdominal examination. So when it comes to the methods of contraception that are available, we'll say that, Stephanie, that because of your condition of the breast cancer, the hormonal methods cannot be used because it is a hormone dependent cancer. Okay, so we have got 4 options, and for each of the options you will give the mechanism of action, the failure rate, pros and cons, and any side effects. So the first option that we have got is that of a copper coil. It is toxic to sperm and eggs, and it also prevents the pregnancy from getting attached to the lining of the womb. The failure rate is around 0.8% or less than 20 in 1,000 women or 5 years. Okay, and the advantage is that it is a long-acting method, that it can be used for 5 or 10 years, depending on the type of copper T device that will be used. And it can have, during the insertion, you might have some pain. There is a risk that the copper coil can be expelled outside, and during the periods, it can give you heavy bleeding. Okay, so you have, for every option, give all these details so that she can then make an informed choice for herself. Then the second option is that of a barrier method, in which we can use both male and female condoms. The failure rate is quite high. It is at around 18%, and it is not a very reliable method of contraception. The third option is a permanent method. We call it as sterilization. It can be done in both males and females. The failure rate for female is 1 in 200, and for males is 1 in 2000. And the drawback is that it is a permanent method, and the reversal is nearly impossible. Okay, so you have to give details. And the side effect, that it is one of the surgical procedures. So this is one of the drawbacks, that it is a surgical procedure. Then the fourth method is that which is achieved with the breastfeeding. We call it as lactational amenorrhea, and it can be effective in 98% of the cases if there is exclusive breastfeeding and you are not getting any periods and you are 6 months after the delivery. So these are the 4 options available So then you have to ask that, am I being clear about the options? Make sure that she knows about all the options and the details. However, the best option is that of a copper coil, because that is going to give you a reliable long-acting method of contraception. So then you have to ask the patient if you have any preferences for any of the method, and naturally she will opt for copper IUD because that is going to give her a reliable, suitable, long-acting contraception method. So copper IUD, it can be inserted within 48 hours of the delivery. It can also be inserted post-placental within 10 minutes of the delivery and within 48 hours. But if 48 hours has passed, then you cannot insert it until 4 weeks. It becomes a UK MEC3. So we cannot insert it. And during this time, we will give her some other bridging method. And however, if the patient comes after 4 weeks, then it becomes UK MEC1 and you can give her. So Nazia, she was on the 21st day, right? And you said that we can insert the copper coil for you. So you cannot insert it until 4 weeks. You'll have to wait for 4 weeks. Okay.
Okay.
And then another contraindication is postpartum sepsis, in which it is UK MEC4. And then you give the patient some patient information leaflets, and you will say that we'll see you back in the clinic in a week's time. We can organize this for you, and you can have it fitted here in the clinic. After we have fitted it for you, you'll have to feel for the threads within the first 4 to 6 weeks after it is inserted, and then on monthly interval after your periods or menses. So now I will show you some of the slides from FSRH and the postpartum contraception TOG article. It gives some of the exclusion criteria for the PPIUCD insertion. The pregnancy specific are the postpartum sepsis, prolonged rupture of membranes, and unresolved PPH. And some general contraindication that we all know: PID, unexplained abnormal vaginal bleeding, and then abnormal uterine anatomy. And here are the failure rate of all the methods from the FSRH guideline. So in any of the, it can come as some other station. There was one station with postpartum contraception where patient wants contraception and she has epilepsy, right? We will discuss that as well. It can also come as a structured discussion, and for that purpose, I have it one of the slides from the FSRH guideline. So whenever the patient asks, we have got 6 reliable methods of contraception, right? 5 of which are hormonal, and only copper IUD is non-hormonal. So right after the delivery, even patient, if it is patient is breastfeeding or non-breastfeeding, for all of these women, the implant and POP, both of these options are UK MEC1, right? They can be given right after the delivery. Okay, and then comes the option of DMPA and combined pill. So DMPA can also be given in the breastfeeding patients. And however, the combined pill in less than 6 weeks in the breastfeeding patient, it will be a UK MEC4. So you cannot give it in the breastfeeding patient who are less than 6 weeks postpartum, right? And now we'll talk about the non-breastfeeding women. In these patients, again, DMPA can be given. However, if they are less than 3 weeks, whether the patient has a risk factor for VTE or even without risk factors, it cannot be given because it is either a UK MEC4 or a UK MEC3. However, between 3 to 6 weeks, if the patient has risk factor for VTE, it cannot be given, but without risk factors, it can be given. And obviously, after 6 weeks, it will become a UK MEC1. So what are the risk factors? The risk factors are immobility, transfusion at delivery, BMI more than 30, PPH, cesarean section, preeclampsia, and smoking, right? So these are some of the important points. So the patient safety was confirmed, the patient identity at the start, contraindication to hormonal contraception. Both of these were covered by Nazia, and the correct UK MEC option. Nazia, you have to do a little bit work on the applied clinical knowledge, okay? And then the side effects were discussed and the failure rate. And then in the applied clinical knowledge, there should be knowledgeable of the various forms of contraception. We gave her different options, demonstrated an understanding of the UK MEC, and familiar with the NICE and FSRH guidelines. Information gathering was, you have to take her sexual history, for how long she wants to take contraception, and if she has previous history of PID or STIs, all these are included in the history, and if she is in a stable relationship, that is also important for us. request for and review of obstetric notes, which Nazia did, and request for appropriate investigation, including a general examination, BP check, abdominal, and pelvic examination is important. All of these are covered in the information gathering. Then communication with the colleague was giving a feedback to the GP, and we may also refer the patient if we are not sure of which method to give, then we can refer them to family specialized family planning center. Communication with the patient and families was clearly outlines the chosen method of contraception. We gave pros and cons of each method, and we explained the rationale for contraindication for hormonal contraception, summarizes discussion and checks understanding by the patient at the appropriate intervals, which Nazia has learned very well. And thank you so much, Nazia, for this beautiful station.
Thank you, ma'am.
So do we have any other questions? I have one question for all of you. This patient was wanted a postpartum contraception, and she was epileptic, and she was on carbamazepine. What would be our options?
And first of all, the barrier method.
Okay.
Then the POP.
POP can be used.
I think enzyme inducer. COC cannot be used. POP, I'm not sure. I think no hormonal contraception can be used because the levels might get deranged by the hormones. So we would be giving her barrier method, and then after completion of the 6 weeks, we can go for copper T.
Okay. Do we have any other answers?
We can give a depot injection and implant.
Mm-hmm.
Only.
We can give depot and
Yes, we can give
implant.
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 Who is this?
It's me. Fu.
Okay, Fu. So, Fu, I would encourage you and Nazia, both of you, to just go through the guideline of epilepsy, right? So, we will divide the patient medication into enzyme inducers and non-enzyme inducers. So, for the non-enzyme inducers, all the methods can be used, right? There is no contraindication to any of the methods. But for the enzyme inducers, the IUCD and IU intrauterine system or Mirena and the DMPA. All three of these can be used, and they are not affected. Okay, so they can be used. You can also do sterilization if the patient wants. However, the combined pill, the POP and implant, these three cannot be used. The efficacy of the medication is affected by these medication, right? So COC, combined pill, POP and implant. We are not going to use three of these. Okay, Nazia.
Okay, ma'am. So we would be using injectables as one, UK MAC1 and Marina and copper IUCD. All are one.
All are one,
Okay.
yeah. And COC, POP implant cannot be used. Okay, Fu?
Cannot.
Yes, ma'am.
Okay, so Fu, would you like to take the next station?
I don't think so.
Yeah, go ahead. Because this is your opportunity to present, okay?
I haven't prepared very much.
It's okay. It is
would
one
that
of the
be
new
fine?
exam station which no one knows about. So it's okay if you haven't prepared it.
Okay.
Okay. Just follow the routine template that we follow, and any patient which comes in your clinic, how you are going to manage that patient. Okay. So just be yourself. Let's see.
Okay, ma'am.
So this is the station, and let me know when you have completed the reading. I'll start the timer.
school starts.
बोले ना
क्या
क्लास से कैसे कर रही है
ये होती है ना इतना क्लास होती है
हमारी नहीं होती छोटे बच्चों की
ये तो ऐसे ना पेशेंट की वो हिस्ट्री दे रही है मैं सिर्फ देख रही हूँ मुझे क्या क्या आता है क्या मैं रिवाइज कर रही हूँ अपना हम भी पेपर दिया था ना सीपीएस पार्ट 2 का तो हम भी ऐसे पेशेंट की हिस्ट्री देते थे मैंने
Someone's microphone is on. Can we mute it?
I'm ready, ma'am.
Ready? Good.
Okay.
Okay, so let's start. Your time starts now.
Hi, I'm Dr. Poo, one of the senior doctors, and this antenatal clinic today. May I confirm your name and age, please?
My name is Helen Byrne, and I'm 25 years old.
How may I address you?
Helen is fine.
Okay, Helen. I understand that. I understand that you're here. You're coming today to discuss with me regarding some problem with your blood test. Am I right?
Yeah, that's right, doctor. I just had my routine blood test, and the midwife has rang me that there's some problem with the blood counts, and I'm really worried, and that's why I'm here.
Okay, Helen, don't worry. We are here to help you. So before we go through your management plan, I would like to ask you a few more questions to know more about you. And at the end of the discussion, we will make the safe mutually agreed management plan, and I will give you the patient information leaflet. Would that be fine?
Yeah, I'd appreciate that, doctor.
Okay, Helen, could you please tell me more about this pregnancy?
So, doctor, this is my first pregnancy.
Okay. How has your pregnancy been so far?
The pregnancy has been fine. I had my booking bloods and a scan done. Then a scan was done at around 20 weeks. Everything has been going good so far. This is my first pregnancy, and it is a planned one.
Okay. Has there been any problems like fever or infection in a recent illness or recently?
No, I haven't been recently ill.
Okay. Have you tested for Down syndrome screening?
In the start of pregnancy, yes, I had the Down screening, and it was normal.
Okay. Has there been any bleeding down below during the pregnancy?
No bleeding. Although in the start of pregnancy, I did have a lot of vomiting, but it settled on its own.
Oh, have you noticed any, easy bleeding or bruising on your body?
No, doctor.
Okay. So this is your first pregnancy, right? So do you have, are you aware of your blood group?
It's AB positive.
Do you have any reservation for blood transfusion if there is any need for transfusion?
Why, doctor? Are you? Is there a need for transfusion? Are you going to
And
give me a blood
reservation for blood transfusion if it is necessary?
Okay, I don't have any reservation.
Okay, Helen. Have you? How was? May I know when was your last menstrual period and your period history?
Yeah, my cycle has always been regular.
So, do you know the current duration of your pregnancy?
Yeah, it's 28 weeks.
Oh, okay, Helen. Have you used any contraception before?
We have only been using condoms in the past.
Okay, Helen. Are you medically fit and well before?
Yes, doctor. That is why I'm worried. I have never been ill, and I don't have any problem. Like I don't have any medical illness.
I understand your concern, Helen. Okay. Do you have any family history of bleeding disorder or in your family?
No one in my family has such problems. Only my mother is diabetic.
Okay. Have you had any surgery before in your lower tummy or down below?
No, I've never had any surgeries.
Okay. Are you taking any medications?
No, just the pregnancy supplements I'm taking.
Are you allergic to any medicine?
No, I don't have any allergies.
Okay. Do you drink? Do you smoke? And pardon me asking, do you use any recreational drugs?
I used to drink occasionally before pregnancy, and I did used to use some drugs back in the college days, but I had stopped it a long time ago.
Okay, I appreciate that, Helen. What do you do for a living?
I'm working in a superstore as a manager.
Okay, so how's your support at home?
Yes, my partner is very supportive, and we are both very excited for the pregnancy.
Uh-huh. Okay. Have you been feeling low mood, depressed, or tearful during these 2 weeks?
No, not really.
Okay, Helen, thank you for sharing the information. Do you want to add anything?
No, I think that's all.
Okay, Helen. In a few minutes, in the presence of a chaperone, I would like to examine you. My nurse will measure your blood pressure, and we will measure your height and weight, and calculate your BMI, and I will feel your tummy. Would that be fine?
Yeah, that's all right, doctor.
Okay, Helen. Now I have the report in my hand. It is confirmed by your name, age, and initials number, and it is your report. And we found out that your platelet count is low, which is 70. Do you have any idea?
No, doctor. I'm just worried that what is this going? How is it going to affect me and my baby? Is it serious?
Okay, Helen, I will explain you. The platelet is the material in your blood. It's a protein in your blood, which is responsible to stop bleeding, and this should be up to at least 150. And now you have reduced you have decreased platelet count, which is only 70. And this could be due to some kind of problems. Like during pregnancy, this is because of the physiological natural. Some women may have this kind of problem, and this is not a serious problem. If this is until 100, as low as 100, and sometimes it could be due to some immune factor. In this problem, your body fight back against your own tissue, and this might happen. This problem might happen. In your case, your this platelet level was normal at your booking visit, and it has been decreased after 20 at the second half of your pregnancy. It may be due to the pregnancy. Your platelet count became decreased, but at the moment your platelet count is less than 100. So we have some precautions to make your pregnancy safe. Are you following me?
Yes, doctor.
Okay. Let's share. I will discuss regarding your continue your upcoming management plan. Okay.
Right.
So we will the team of doctor involving consultant obstetrician, a blood doctor, and special clinical nurse, a specialist clinical nurse will take care of you, and you have to come to your following antenatal visit to the consultant-led unit, and we will retake your blood, including platelet count, monthly, and it will be more frequent if it is necessary. And and if there is any concern, we will do some further management, and it will be according to your individual condition.
Okay.
So we will do some ultrasound to assess your baby's growth and your baby's well-being monthly, every 4 weeks. It is what we call crowd scan and if there is no concern, we at 36 weeks, if all of your condition is normal and the baby is in normal position, we are aim for the vaginal delivery unless there is no indication for cesarean section.
Okay.
Am I?
Yes.
Okay, Helen. For delivery, you should deliver at a hospital under consultant latch unit, and at the consultant unit, and if not under consultant latch unit. When
Any precautions during the delivery?
During delivery,
your time is up, Fu. So
sorry?
close the station. Your time is up, so close the station.
Oh, okay, Helen. We will take care of. We will do continuous monitoring of your baby's heartbeat during delivery, and we will avoid instrumental delivery, and we will do our best. And I will fix an appointment with my consultant for further discussion regarding your condition, and I will write back to your midwife regarding our discussion today. Thank you for your time.
Thank you for your time, doctor. Very well done, Fu. For the first time presenting and with an unknown station, this was a very good attempt. Okay. So your intro and agenda making was very good. We came to the history of presenting illness, in which you did ask about all the pregnancy questions of how far she has been pregnant and how has the pregnancy been. For a patient who is at 28 weeks, you can also ask about the fetal kicks. Okay, so that you can ask about if the baby is kicking or not. So this is you can for the baby's well-being, right? And try not to repeat the information which is given in the candidate instruction. Okay, because sometimes the role player can get irritated because they are going to say that, yeah, it has been written in the in my notes, which they means that it has been written in the candidate instruction, so they don't want any information which is given to be repeated. Okay, so it was written that she is 28 weeks. So try to cut down on this habit, although it is possible, like you can have you can ask, but try to avoid this. And then we came to the history of any bruising, any you could ask about some more questions, like any bruising when you any excessive bleeding when you cut yourself, or during any dental procedures. You can ask about, you did ask about fever or any flu-like illness can also be asked. And then you completed the whole history template, in which the one most important point was the family history of bleeding disorder, which you have covered. So very good on this point. And when the patient is said that she came here for the because of the low count, so you can ask about the any previous counts, blood counts which were done. Most of the times patient will have it done at booking, so you can say that when your bloods were done at the booking, are you aware that were they normal, were they okay? So she will tell you that at the booking they were either normal or there were some derangement or something. Then we covered the examination part, and you covered all the points. At every antenatal visits, we routinely do the urine protein. Okay, so try not to miss it here, because some hypertensive disorders are also associated with thrombocytopenia. So we'll check the blood pressure and the urine protein. That is a must.
Yes.
And explanation was very good. You can say that these are the small cells in the blood which are responsible for stop the bleeding. And then you said that the count above should be above 150. To 400 is normal. However, your count has come out to be 70. And physiological was a jargon, right? So then you covered it with by saying that it is a natural decrease in the pregnancy. So that was fine. And you confirmed the name and NHS number, very good. And then you explain the causes, which can be either gestational thrombocytopenia or ITP. You beautifully said that there are autoantibodies. Antibodies are produced proteins which act against the body's own tissue, and when they act against the platelets, they can destroy the platelets, and that is when the count becomes low.
Yes.
And then we came to the management. It was a multidisciplinary team management. And you did repeat the platelet count to see the trend. I will tell you about some further investigations that we can do. And if the
Yes.
baby is growing fine, there shouldn't be any indication for serial growth scans, right? If on the examination the fundal height is 28 weeks, then it should be okay. We don't need to do serial growth scans, just the routine antenatal care for the baby. And then
Yes.
intrapartum care was we will aim for vaginal delivery. And although it was after your 10 minutes, but you did say that we will avoid using any instrumental deliveries. So these are some of the very good points that you have been covered. And what is your own perception of the station Fu? How did you do it?
Me?
Yeah.
So I don't understand. And so what is how did we do, how did I do?
How did you find it? Was it difficult for you or was it okay for you?
Actually, we usually encounter this kind of patients in our clinic,
In
but
a clinic,
you
yeah.
know, now like this exam approach, I'm not satisfied with my presentation, and I need to do a lot more for
Yeah,
time management. And
time
actually,
management.
I have in my mind this pre-eclampsia BP and BP urine protein was in my mind, but I missed to
Okay.
mention in my presentation. So I need to do a lot more.
You need to practice a lot more, okay? Because the exam is in November, right? So you
Yes.
need to do more and more practice. So the things which are coming in your mind, you have to speak them. And then time management is very important. Whenever you are practicing with your study buddy, always set the time for 10 minutes and try to do close the station. Closing means that you have given the whole treatment plan. Ask the patient does she have any other questions? And you have given her the patient information leaflet, and you write back to your GP or give her the next appointment with the consultant. Okay. So all these points are very important. Now let's discuss the station. I've prepared slides for you. So intro and agenda making for a patient who is coming back to the clinic to discuss the reports. You can say that I can see that you have come back to the clinic to discuss the reports. Is that right? And then she will say that yes, it is about the blood counts. And a first question should always be an open question. Is this your first pregnancy? Was it a planned pregnancy? How far you are pregnant? If the patient is in second or if the patient is in third trimester, you don't need to ask about the question of first trimester, like the whole booking and the down screening and all that. So if everything has been fine, she will say that pregnancy has been going good so far. And then we'll ask about the baby kicks. We'll ask about the blood group. Has she been recently unwell or admitted to the hospital? Any scan or blood tests that were done recently? And any previous blood test is very important because that will give you an information about the trends of the platelet counts. Then we did ask about a history of bruising, any nose bleeds, gum bleeds, menorrhagia. Previously during the periods, were there any heavy bleeding during periods? Any bleeding from the back passage or with the passing urine? Any bleeding after a dental procedure? And with any viral illnesses, we know that the platelet count can go down. So we'll also ask about any flu-like symptoms or any fever. Then we'll ask about the obstetric history, mode of delivery, recovery, her last menstrual cycle, and contraception. You did miss about the cervical screening, right? So in this patient, if she was 25 years old, maybe she will say that I had my first, I was the first appointment for my cervical screening sent, but I had to wait because of the pregnancy. So any patient above 25, make sure that you ask about the cervical screening. Then the medical history, surgical history, family history of bleeding disorder is very important. Any blood thinning medication that she might have been taking, and then the allergies, BMI, blood group, smoking, alcohol, recreational drugs, and social and mental history. On the examination for any antenatal patients, we'll do a BP and urine analysis as a must. Okay. And then look for any petechiae, bruising, gum bleeds. Then we will do some investigation. Obviously, it is a thrombocytopenia. So we need to find out the cause of this thrombocytopenia. What can be the causes? The causes can be gestational thrombocytopenia, ITP, and then it can be even some hypertensive disorder like preeclampsia, thrombotic thrombocytopenic purpura. And then there can be some viral illnesses and rarely hematological malignancies. Okay, so we will do a full blood count. We'll compare it with any count which has been done before and repeat it in a week time to check the trend. A peripheral blood smear should be done because in conditions like TTP, it can show some schistocytes on the peripheral blood film. Then we'll do a virology screen like HIV, CMV, and then a liver function test, UNEs, urates, and coagulation screen. If all of these are negative, the diagnosis of exclusion will either be what? A gestational thrombocytopenia or ITP. In the exam, it will be mostly these two, like either gestational thrombocytopenia or ITP. And that is what we most commonly see in our clinics as well. Okay, so these are all the causes which Fu has mentioned. And then effects on mother and baby. For the mother, there can be increased bleeding tendency. The choice of pain relief can be affected because she cannot have epidural, right? And then for the baby, there is a risk of fetal or neonatal thrombocytopenia. And rarely there can be a bleeding inside the baby's brain. You can say this to the mother. So the antepartum clinic will be a multidisciplinary team. It will be a joint clinic between the obstetric consultant and the blood doctor. Will also take a review from the sleep doctor and the baby doctor. We will repeat the count in a week's time and see the trend. If there is severely low counts or if they are rapidly falling counts, then we'll involve the blood doctor. We'll consider a trial of the medication, a steroid medication, which we call it as prednisolone. We'll start from the low dose and we'll check in a week's time. If there is no response or inadequate response, then we'll increase the dose. There can be some immune medication which can be given through drips, and very rarely, in extreme situation, we may need to give a platelet transfusion as well. We'll inform the baby doctor, and bone marrow biopsy sample of the bone marrow can be taken if there is severely low counts and or if there is no response to the treatment. Then during the labor, it will be the delivery will be in a consultant-led unit. The sleep doctor will review you to discuss the option of pain relief with you. Epidural can only be given if the count is more than 80. If the count is less than 50 or 50, then we will have the platelets on standby. We'll aim for a vaginal delivery and we'll avoid any sampling from the baby's scalp or any instrument to be used on the baby's scalp and any instrument to deliver the baby. After the baby is born, we will inform the baby doctor. And if your count is low, then a sample of blood will be taken from the cord at the time of delivery to look for the platelets count. If they are low, then a further sampling can be done at day 1 and 4th day of the delivery as well. The vitamin K will be given by mouth to the baby and will avoid any injections. If the baby is having severely low counts, then we will organize for a brain ultrasound scan. And if the counts are low, baby can be given medication through drip, and also platelet transfusion can be given. For you, we will repeat the counts in 6 weeks' time, in which time we expect them to come back to normal. Okay, so this is how you are going to complete the whole station.
Doctor, I have a question. Maybe confusing my question this time.
Okay.
We should exclude, you are right, we should exclude other cause of thrombocytopenia, and we concentrated if it's ITV or if it's gestational thrombocytopenia.
Yeah.
I mean, gestational thrombocytopenia, I think it should be certain limit of a platelet count. I mean, not continuous drop, right? Or it is near 100 multiplied by 10 to the power 9, right, Doctor?
Anam, what I can understand from your question is how we are going to differentiate between gestational and ITP. You have rightly said that in gestation, most of the time the count will be more than 100, and rarely they are more than more than 80. They are not going to drop from lower than 80, 70 or 60 or 50. In ITP, we see that patient even have counts of 20,000, 25,000, 30,000.
Yeah, correct.
So in the gestation, counts are going to be good.
Oh, okay, doctor. And the second question, which is important, doctor, gestational thrombocytopenia, you mean it is occurring during a pregnancy and resolve after delivery? So it will affect
Exactly.
the mother rather than the baby, or it affects the baby like ITB, because suppose ITB is autoimmune, right? So autoimmune, it's immunoglobulin G.
Yeah.
Transfer to the mother to the baby and will
So
hit
Anam, the
the
thing
baby.
is that gestational thrombocytopenia is a very mild condition. The counts are not very low. If the counts are not very low, it is not going to affect mother or baby in any way. We just need to monitor the counts during the pregnancy.
Oh, okay. So during
Okay.
delivery, the problem, doctor. So there is no, I mean, we scared for the baby only for ITV, not for gestational, but we should accurately confirm it is gestational rather than ITV. Otherwise, if there is any intervention to the baby or any, it will be.
Anam, this is what the station is about. Because if for the
ITV.
gestational thrombocytopenia and ITP, you don't have any, lab investigation to diagnose both of these. Both of these are the diagnosis of exclusion. If the platelet count is good, more than 80, you can say that it is gestational thrombocytopenia. But if it is less than that, then obviously you will definitely take precautions. For the epidural, it should be more than 80. For the operative vaginal delivery, what should be the count? Can anyone tell me?
About the 50, doctor, for vaginal delivery.
Yeah, right.
Yeah.
More, it should be more than 50. For a vaginal delivery, it should be more than
Vaginal delivery 50, doctor. Vaginal operative 50, and cesarean, I think epidural spinal 80.
epidural spinal 80, vaginal delivery more than 40, and operative vaginal delivery more than 50. So you can say 40 to 50.
Cesarean, doctor, what about cesarean? Oh, there is no problem.
Cesarean will also be in spinal, right? So
it's
it is the same as epidural.
Yeah,
if the count is very low, you are not going to do it in the spinal. You will give a general anesthetic, right?
Yeah, doctor, because I have one case, but it's long time. It was diagnosed during the pregnancy. It was third trimester, but it started to drop in the platelet count, and then they put her on a steroid. I mean, this is ITB. It's like ITB rather than gestational. So we shift her to the tertiary center because there is risk to the baby and to the mother.
Exactly. So, Supan, which slide you are talking about? Or was it from the previous station?
No, first slide of your thrombocytopenia.
Okay.
One.
Is this one you are talking about?
Yes, thank you.
No problem. So Amarzish is saying that if it is gestational, then should come back to normal after 6 weeks, and ITP counts will be low even after 6 weeks. Yeah, because ITP is a chronic condition, Amarzish. So it will, most of the patients, 2/3 of the patients, they are diagnosed before the delivery, and when they are pregnant, we know that they are ITP, and the counts can come more down during the pregnancy. And that is when we give them these steroids, medication, IV immunoglobulins to bring the count up. And rarely we have to give them platelet transfusion as well. So obviously ITP is a chronic condition. Gestational thrombocytopenia is only limited to the delivery. But when this station come in exam, you will take both of these side by side. You don't have to give an exact diagnosis. You just have to give your differentials, right? And then you have to say that what is your antepartum, intrapartum, and the postpartum management.
Ma'am, one question. Do we have to give the option of plasmapheresis?
Plasmapheresis, no. Plasmapheresis and plasma exchange are for TTP. In ITP, we'll give IV immunoglobulins. Okay. So information gathering will do a concise and relevant medical history who has taken, able to ensure that the patient understands and encourages question and initiates appropriate investigation. So the investigation, these are the investigation that we requested, right? The full blood count, a peripheral smear, and virology, and some liver function and renal function tests. And then discuss the implication of low thrombocytopenia in pregnancy on mother and baby we have done. And obviously it is going to be an MDT plan. The patient safety is having an understanding of the limits of their clinical abilities. And that is why we have involved other disciplines like anesthetist, hematologist, and a neonatologist with us. Discuss the risks and takes necessary precautions against it. All the precautions that I have told you, avoiding instrumental delivery, fetal electrodes, when to do give epidural, all these are the precautions. And will give information sensitively in a manageable amounts and regarding results of investigation in the management of each part of the pregnancy, and describes a clear and logical action and rationale for follow-up. So here's one of the slides from this is some Scottish document which I've obtained, and it is very good in terms of like it is a flow chart for how we are going to look after the patient who have low counts. So if the counts is less than 120, there is no history of ITP, then you will do a blood film. However, if there is a history of ITP, you know the patient from previously that she has ITP, then you will liaise with the hematologist and they do the treatment, monitor and treat below the intervention levels. They will either give steroids, immunoglobulins, and that is how they are going to treat. And if the patient has medical disorder or any drug history, then we'll treat the medical disorder and withdraw any drugs, any medication that she has been taking, any blood thinning medication, and then we'll repeat the count. However, if there is no ITP, then you will perform a blood film. If there is on the blood film, there is only isolated thrombocytopenia, and the count is more than 70, then it is likely to be a gestational thrombocytopenia. You will only have to monitor. If the count is less than 70, then it is likely ITP. Then you will again involve the hematologist and treat below the intervention level, right? And monitoring, it will be monthly in the first and second trimester, fortnightly in the third trimester, and weekly from 36 weeks onwards. Now we came to the blood film which showed any schistocytes or microangiopathic hemolytic anemia. We'll do a UNEs, LFTs, and coagulation screen. If they are abnormal result and there is hypertension along with proteinuria, then we are either suspecting preeclampsia or HELP syndrome and treat it accordingly. If there are abnormal results along with the symptoms of TTP, so in the TTP there's a pentad of symptoms: microangiopathic hemolytic anemia, thrombocytopenia, and then there is fever, kidney symptoms, and neurological symptoms. Then we'll treat it on the line of TTP. And for HUS, there should be a preceding history, malaise, coagulation dysfunction, and that is how we are going to do. So basically, it is a multidisciplinary team management. For the obstetrician, we basically have to manage this thing. Gestational thrombocytopenia, even with ITP, we have to involve the hematologist. So this is all about low platelet count in the pregnancy, thrombocytopenia. Do we have any other questions?
Hello.
Hi.
Hello. I'm Supun. When patient has gestational thrombocytopenia, how frequently you monitor the platelet count?
Yeah, so you can either follow this flow chart, right? So in this flow chart, it is monthly in the first and second trimester when she goes closer to the delivery time. So obviously in the third trimester, you will do it fortnightly. And from 36 weeks onwards, now you are planning the delivery, right? So you will be worried about the use of epidurals, the use of instrumental deliveries, all that will be in your mind. So you do it weekly to see the trend. And if anything like any low counts, then you do interventions.
Okay, thank you.
You're welcome, Sopan. So thank you so much, Tabassum and Nazia and Fu for participating. It was a lovely session. I enjoyed it myself as well. And I also invite you all to our one of our crash courses that we are doing from the Med Exam Expert. We'll be starting it in the second week of September. And it is a rapid revision course. Basically, we want to utilize this short time maximally to discuss all the important stations. So myself and Dr. Maryada will be doing alternate session. We'll cover all the 14 modules, and we will try to cover most of the stations in the live sessions. And if at all they are not covered in the live sessions, then we'll give you some written material and some audio material, so that in this short time you don't have to go through the guidelines and stuff. And we'll try to give some ready-made things to you so that you can do it really quickly for the exam preparation. And best of luck to all of those who will be participating for the November. Try to find a study buddy from now onwards and participate and practice on daily basis. That is the most important thing. Are you there? Fu, are you there? Do you have a study partner?
Yes, I have.
Okay. All right. So do it on a daily basis, okay?
Yes,
Because
I will.
this exam is all about, we all have the knowledge from the part 2 and we know all the guidelines, all the talk articles. All we need to do is practice and time management. This is very important. Rushna, do you want to ask about something?
Hello, ma'am.
Yeah, hi, Rushna.
Hi, ma'am. I wanted to ask for the steroid. If we are mentioning about steroids, then we should mention about growth scans every 4 weekly, or no need?
Yeah, only when you are giving steroids. Yeah, you can talk about. But for some, like a patient who has normal, like you are not doing any intervention and the fundal height is normal, then obviously even in our clinics we don't do them for low platelet counts. We don't do serial growth scans, right? But when you are giving steroids, then if the patient, you have to start the patient on steroids, and you obviously you will discuss some of the side effects of steroids, like there is a risk of increased blood sugar, there is a risk of postpartum psychosis, all that. And in that case it can be considered, yes.
Okay. Thank you, ma'am.
You're welcome. So do we have any other questions?
Maybe it's, I don't know really. Shall we know some information about TTP and hemolytic uremic syndrome, or if this is multidisciplinary in case we suspect such case? Also?
Anam, your voice is very...
Oh, sorry, doctor, because I put it down. Yeah, shall we know some information about TTP and hemolytic uremic syndromes, or no need, doctor? Just it is part of hematology.
You can say that some of the disorders which are associated with raised blood pressure, you don't take, all the fancy names in front of the patient. Thrombotic, thrombocytopenic purpura, hemolytic uremic syndrome. So you just discuss about the gestation thrombocytopenia, ITP, and then obviously some problems with the raised blood pressure, along with the protein in urine.
I mean, structural discussion, if maybe it comes as.
Yeah, in structural discussion, you definitely have to go through everything. Yes.
Thanks, doctor. Thanks for your information.
You're welcome. When are you appearing for the exam, Anam?
Doctor, I'm for MRCPI.
Oh, you are for MRCP. Okay. When is your exam?
November supposed.
Okay.
Inshallah.
Good luck. Okay, so thank you so much, all of you, for participating. It was a lovely session, and we hope to see you in our rapid revision course. Where will be, so basically in the concept of rapid revision course is to cover more and more things in a short period of time. So even if you have previously taken a regular course, or even if you have not taken it, we'll give you all the material, and we will guide you how to prepare for this exam in a short period of time and do things very quickly. But we'll give you time to absorb all the things, and we'll be supporting you right through the exam day. So thank you so much. I think that's all from my side. If we don't have any other question, then we will stop the meeting. Thank you so much, and Allah Hafiz, and bye-bye from my side, and good night.